Hi, everyone. This is Joe Gallo, board member of ASPE and also an advocate in the prostate cancer arena with ANCAN. I'd like to welcome you to another segment of Active Surveillance 101, AS 101. And as you may already know, this series has been created and sponsored by a coalition of both US and the Canadian support organizations. In just a moment, you're going to hear from Phil Siegel from one of our Canadian organizations, who will give an update over the objectives of this program.
Today, the Active Surveillance Coalition is presenting another installment in its AS 101 series. The Active Surveillance Coalition is comprised of ASPE, the Active Surveillance Group within ANCAN, Howard Walensky, and the Active Surveiller, Prostate Cancer Support Canada, and most importantly, PCRI, who help in filming and editing these webinars. This webinar continues to feature Larry and Nancy White, a couple from New Mexico who have been through this journey and are our model patient team. They are visiting Dr. Andres Correa, a urologic oncologist at the Fox Chase Center in Philadelphia. This webinar is focused on the role of imaging, multi-parametric MRI, and micro-ultrasound in relation to active surveillance. Let's begin the webinar now.
Good morning. I'm Mark Lichty, and I'm chair of Active Surveillance Patients International. And for those of you on the active surveillance journey, you will find that this is one of the greatest gifts of your life. You're going to meet people that'll walk this journey with you, and they will become friends for your life. Things have really changed so much in the past 18 years since I've been diagnosed with prostate cancer. Back then, one automatically got a biopsy. If they had doubled their PSA in 1 year, then you just got a biopsy. There was no MRIs, there were no other monitoring approaches that were available. Today, my urologist, Dr. Correa of Fox Chase, is going to speak about micro-ultrasounds and MRIs. And I really want to say a word about Dr. Correa. Dr. Correa really understands the patient-doctor relationship. He understands the need to reduce our anxiety, to minimize intervention when not necessary, to minimize pain when not necessary. And I just wanted to say that he's always open to feedback from me as well. I'll bring him articles or give him information, and he's always quite open. And that's really what I'm looking for. And I suspect that you all too are understanding, wanting to find a doctor that really understands your needs. And I wanted to thank Larry and Nancy White. They've been real troopers on this Active Surveillance 101. If you check out our website, you'll see all of the Active Surveillance 101 programs, and they've done such a great job. We're also grateful to the Prostate Cancer Research Institute. Had it not been for the Prostate Cancer Research Institute, there would not be an ASPI, an Active Surveillance Patients International. There wouldn't be this coalition at all. And Mark Schultz, Alex, Peter Schultz have been such a support team for us in doing this video. They're editing, they've edited the video, and we really appreciate all the work that you've done. And I guess I feel a need to even thank my father for this active surveillance journey. He had prostate cancer, died of prostate cancer, died with over treatment of prostate cancer. And but for my father, I would not have been inspired to go on this active surveillance journey. And there is no question after 18 years that this is the journey that I should have been on. And so the whole arena of imaging is evolving, and it's exciting to be a part of it, and it's exciting to see what Dr. Correa has had to offer. He's very much a part of the evolution of the imaging area too. So with that, I'd like to introduce Larry and Nancy and Dr. Correa. Thank you.
My name is Andres Correa. I'm one of the urologic oncologists at Fox Chase Cancer Center who specializes in prostate cancer. It's a pleasure to meet you today.
Well, hi, Dr. Correa. I'm Larry, my wife, Nancy. We've been dealing with my prostate cancer here for a number of years. And Nancy has done quite a bit of research and educated me. And we're trying to basically get with you to figure out what we're going to do with active surveillance. One of the things that we've done is written some questions down so we don't forget. We get a bit nervous in these meetings. And the other thing, would wonder if you would mind us to record the session so when we leave here, we're able to remember what you said and such. Would that be okay?
100%.
Okay, great. What we've decided is to continue with active surveillance after I was diagnosed with prostate cancer. I had a PSA of 6, followed by MRI-guided transperineal biopsy. I had a Gleason score of 3+3, and that was verified by 2 independent pathologists. I've also had a BRCA testing, which is negative, and we also had genomics testing, which were favorable. So, based on all the information we've learned, based on my testing, we decided that active surveillance was probably a good course of action. But I will tell you that in the back of my mind, I do have a concern that since we didn't biopsy the entire prostate, that there could be some more severe cancerous cells that weren't found, and that we may miss it with the active surveillance, and then metastatic disease. So, I mean, that's kind of in the back of my mind. It doesn't stop me from this, but it is a concern that kind of sneaks in periodically. I know we're going to do PSA occasionally. I'm not sure how often you would recommend. I know there's different types of imaging. I know there's a possibility of another biopsy, but we're here to talk to you and see what your recommendations are for continuing with active surveillance.
Sure, Larry, my pleasure. I think that, so my understanding of your story is the fact that you had an MRI that showed a concerning lesion. And when they did the biopsy, the only area that they biopsy was the region of interest, meaning the lesion itself, that they didn't biopsy the rest of the prostate.
Correct.
Oh,
Well,
perfect.
I think they took a number of samples that might have been random outside the area of interest.
Oh, okay, so they
Certainly
did. Okay.
Certainly they got I'm not sure how many samples that they took right
Okay.
now. 12 samples.
Okay, perfect. Okay. So I think that there's something that people have been kind of looking into, which is when you have an MRI, and I imagine, do you remember the grade of the MRI lesion? If it was a 3, a 4, or a 5?
PIRADS 4.
PIRADS 4, perfect. So let's talk about that initially. I think that PIRADS classification is very important. So what PIRADS tells us urologists and patients is what is the chances that the area of interest, or that area that the MRI noted as abnormal, actually represents cancer. And the higher the number, the higher the chance it can represent cancer, and the higher the chance it can represent an aggressive cancer. And those aggressive cancers are what we call in our field clinically significant prostate cancers, is anything more than Gleason 6, so a Gleason 7 and above. So we know that in about a PIRADS 4 lesion, there's about a 50% chance that it can be a clinically significant prostate cancer there. For someone with a PIRADS 5 lesion, that increases to 75%. So it's important to know there's not 100%. A lot of patients come into our office thinking that they have cancer just because they have a abnormal MRI, but that's not the case. You need to do a biopsy to confirm cancer. So a lot of people do come very scared, kind of like women come in after they get an abnormal mammogram. They think that they have cancer, but really you don't have cancer until you have a biopsy.
Okay.
Then the next step is doing a biopsy and then what to biopsy. And I think that's now that the field has kind of been moving towards less invasive approaches. Do we only need to biopsy the site of the abnormality, or we do what they did for you, which is biopsy the site of the abnormality, in addition to doing a random sampling of the prostate in case there's other cancers there? It's still pretty controversial. There was a randomized control trial that just was published from Scandinavia that looked at maybe just doing the site might be equivalent. The issue that I personally see with that is that if it's negative at the site, great. We don't have to worry about it. You're in that 50% group of patients that didn't have cancer, and we just do just regular surveillance with PSA. Now, if it's positive, and let's say it's a Gleason 7 or a Gleason 8, the question is, how do we treat you? And I think that that's where the dilemma exists, at least in my mind, is because of the fact that I will not be able to give you a good treatment options without knowing what the rest of the prostate looks like. So to some degree, I cannot say, oh, you're a candidate for focal therapy, because if you have cancer in the other side of the prostate, then I'm under treating you. If there's more aggressive prostate cancer elsewhere, which can happen up to 10% of patients, we might be under treating you as well. So I think that for patients just getting the biopsy in that site is all good if it's negative, but if it's positive, they might be getting a secondary procedure. Does that make sense?
Yes, it does. And, I mean, I had a transperineal biopsy.
100%.
And, I don't know. We've heard both ways, but I mean, would you say transperineal is equivalent to transrectal, or would you prefer one over the other? Or
so I'm a transperinealist. I do transperineal only. I mean, I'll try to take my bias out of here. We don't have any level 1 data that shows that one is superior to the other. I sensically and rationally, well, the transperineal approach is not going through the rectum, so the risk of infection it makes sense to be lower. And I think the retrospective analyses that have been done are showing that that's the case. In our experience here at Fox Chase, we haven't had a patient get infected with sepsis from a transperineal prostate biopsy. So I think that the numbers are holding. That number is supported by our quality collaborative, the PER collaborative, and that is also supported by the music collaborative. So although those data are retrospective based on prospective registries, I think the data is holding. The other benefit too is that there's no rectal bleeding. There's a subset of patients that will have significant rectal bleeding from the transrectal prostate biopsy. And I think that doing a transperineal approach just avoids that. There's no question about it. We're not going to the rectum. There'll be no laceration of internal hemorrhoids. The trick comes in with the procedure and the discomfort associated with it. So I would say that the transperineal approach, in my opinion, might be a little bit more uncomfortable when it comes to the numbing aspect of it. So numbing hurts more, but the biopsy hurts less. So I think that getting the numbing performed, I tell my patients like going to the dentist. Once I numb you, you're not going to feel a thing, but the numbing is going to hurt.
right.
And that's because numbing that muscle is no way for me to go around not being able to cause discomfort when the needle goes into that levator muscle. We have done a study here at Fox Chase that have looked at men that had done transperineal alone versus getting the transrectal and the transperineal. And our data shows that patients that had first the transrectal and then the transperineal, for the transperineal was more uncomfortable, at least in the numbing. So we have data to support that. But again, my opinion to my patients is that, I mean, we're taking a little bit of discomfort through 30 seconds of getting the numbing to avoid some serious consequences such as sepsis and rectal bleeding. So
Exactly.
I hope that answers your question.
Yeah.
Yes.
Well, is the multiparametric MRI, is that the gold standard now?
So for imaging, it is as of now. Now the question is that can we avoid the gadolinium contrast, which is the concern a lot of patients? So
Right.
just to put some context in there, there's been some reports on the fact that patients that have repeating gadolinium, it deposits in the cerebellum. And there is concern the fact that the deposition might lead to some neurological deficits. We don't have that answer at this point. We don't have any data showing that actually there's a causation saying this deposition in the cerebellum actually leads to Parkinson-like symptoms, dementia, or anything like that. We don't have that data, but the concern is there because, well, it's probably not a good thing for something to be depositing there. If it's going to cause harm or good, we don't know. The question is, do we need gadolinium? And the answer is not for most, but yes for some. And let me explain that. So I think that the data looking at biometric, so just doing the contrast without doing the gadolinium, shows to be a very good test in identifying the concerning lesions. So a standard PIRADS 4 and a PIRADS 5 lesion should be identified properly doing just a biometric MRI, meaning no gadolinium. Is where we have those intermediate lesions, especially those PIRADS 3 lesions that highlight with contrast that then become a PIRADS 4. And so those are the ones that gadolinium might be useful. The other place where gadolinium is very, very useful and is actually needed is in patients that already had treatment, either by radiation or focal therapy. It is impossible to know if the cancer has come back without having gadolinium because the diffusion weighted images are just not accurate enough to tell us that. So we need to see if the tissue is taking up the contrast where the ablation was taken. So I think that for those patients, gadolinium is needed. For most patients, probably not, and especially in the fact that we use an MRI for screening mainly. I think that in the future, we're going to move to biometric MRIs, meaning that no contrast, and only use it very sporadically in patients that either have these lesions that appear to be intermediate or in the patients that had treatment that we need to know if they had a recurrence or not.
Right. Has there been any change in or improvement of the
gadolinium contrast? So, I mean, there's been different agents that have been put out there. The reality is that we don't have data showing that one agent deposits less than others. I mean, we have natural elements depositing in our bodies all the time, that we have fluoride in our teeth, we have iodine in our thyroids, and they don't cause any harm. Actually, they're useful for health. So, I mean, I think that it's not a bad idea to not use something that is not needed. I think that's where the field is moving. If you don't need it to do the diagnosis, why use it? You know what I mean?
Right, exactly.
And there are people that need reactions. And I think that there are patients that had renal dysfunction, especially people in dialysis, that you cannot use gadolinium because of the potential toxicity. And while low is not zero, so for those patients, you can definitely use the biometric MRIs and still get a very good diagnosis.
Is the MRI, is it pretty accurate? Is it?
It is. I mean, it's very good. So the data shows that MRI picks up about 90% of clinically significant prostate cancers, and about 10% of cancers will be missed by MRI alone, 10 to 15%. That was the data that the NCI published. So that goes to the question about using the systematic biopsies or the random biopsies in addition to just doing the targeted biopsies, that they showed that by doing those systematic biopsies, you identify 10% more cancers, clinically significant prostate cancers, if you just did the biopsy at the region of interest. Now, to my patients that have a negative MRI, I tell them that we still have to check PSA screening. I cannot just tell you you're done. But I think that the chances that we're going to miss something very, very aggressive is very, very low.
Does it take a specialized radiologist that specializes in pelvic readings to do it, or can any radiologist read?
I mean, I think it's helpful. I think that we're very lucky here at Fox Chase that we have abdominal radiologists that are very comfortable with MRI readings of the prostate. But the reality is that when MRI was first introduced circa mid 2000s, and when it really started getting used in the early 2010s, I think that yes, there were very few people that felt very comfortable doing it. Also, it was an invasive procedure. I mean, when we had the 1.5 Tesla magnets, you had to put an endorectal coil, and a lot of places didn't feel comfortable with that. Now, with the fact that we can use 3T without endorectal coil, and the fact that 3T machines are becoming more ubiquitous within the US, and the fact that now radiologists and the MRI imaging is becoming more ubiquitous within resident training programs, I'm hoping that more just standard radiologists should be able to give you a good reading. So, but yes, I think that getting a second opinion by an abdominal radiologist at an academic institution is always helpful.
Right, especially if it looks a certain aggression.
Exactly, yeah.
Yeah.
Well, I mean, do you think there are enough the radiologists around the nation that it should be something that one would look for, or?
Yeah, I mean, I think that just like the Gleason score, I think that getting a second read from an MRI should not be hard. I think that I mean, even in most places in the US, there should be a radiologist that feel very comfortable. And again, what I'd caution my patients is that where people get held up is in the intermediate lesions, the ones that are likely to be a very small focus of Gleason 7 prostate cancer. The ones that really can hurt you, like a Gleason 9, a Gleason 10, a Gleason 8 large volume, any radiologist should pick that up. I mean, I as a urologist can see that most of the time, you know what I mean?
Mhm.
And so, I mean, to be honest, I mean, I think that those aggressive lesions, I think nobody should be traveling to New York City from like somewhere in Idaho just to get an MRI done. I think that something aggressive should be able to be picked up just by regular radiologists.
Right.
Now, when it comes to those, as Nancy said, those kind of intermediate lesions, that's where the expertise really comes into play.
So I mean, we think that it's important to get perhaps a second opinion on the pathology slides of the biopsy. Do we think that there should be a second opinion on the MRI?
I mean, I think it depends on the urologist. I think the urologist should be able to read the MRI themselves. And I think that as much as we focus on radiologists being able to read them, I think we as a field also need to take the onus and be able to read our own scans. And so again, like any scan, we have kidney cancer scans. Your urologist should be looking at a kidney mass and figure out how concerning it is for kidney cancer. And I think that we as urologists, we can actually put things more in context than a radiologist can. We see the PSA, we see the patient, we see the age. I think that if anything, is the onus should be on us urologists to be able to look at those images and figure out first if there's of high enough quality, if the PIRADS 2.0 classification and standards were met, and two is the lesion there actually something that we need to biopsy or not. Where I'm personally moving forward to is the fact that I think that not all PIRADS 4 lesions need to be biopsied. Again, Larry, I can argue that your PIRADS 4 lesion that was a Gleason 6 potentially can go and go undiagnosed, and you will not be going through all this anxiety about you having prostate cancer. I think that if you look at the Precision trial and you look at all the non-diagnostic biopsies and the ones that found Gleason 6 prostate cancer, about 60% of patients could have avoided a biopsy. And how do we do that? I mean, we can use lesion size, we can use a PSA density, and that's kind of the research that I'm doing right now, folks. Chase is figuring out actually who needs those biopsies, because I think MRI has the potential to really reduce the amount of interventions we're doing on patients.
Without a PIRADS 5 on that particular MRI, I might have avoided it.
I mean, a PIRADS 5 is a little bit challenging. A PIRADS 4, I think that would have been different. So if you have a small PIRADS 4 lesion, I think that if it's less than a centimeter, especially those that are less than like 5 millimeters, I mean, hitting those, even with fusion biopsy, is extraordinarily difficult. You know what I mean? And I think those are deletions that if a very, very small focus of Gleason 7 is there, the chances of that hurting you are really, really low. And we know that because we have now randomized controlled trial data during that 15 years, there's no difference in survival. So I think that we as urologists need to be cognizant of that. So I think that we are becoming very comfortable not biopsying patients with PIRADS 1s and 2s. PIRADS 3s, people still biopsy a lot. I tend to be less aggressive about those, especially if they have a good, reasonable PSA density. And now I'm moving to actually being less aggressive with PIRADS 4s, especially if the lesion is small in size and the PSA density is reassuring. You just follow them on imaging. Because again, prostate biopsies, even a transperineal prostate biopsy, is not free of risk. You know what I mean? And I think that patients don't like them. Patients don't want to have them. And I think that in some degree, I'm fearful that a lot of patients actually don't come to the urologist because they don't want them. And they're like, it's better not to even have to be told that I might need one. And so if we can get that a little bit more towards where we really, really need it and it's indicated rather than just do it for anybody with an X lesion, I think is what we should be forward to.
I see. Well, you mentioned fusion, a fusion MRI. How does that work?
So a fusion MRI in theory in general is an MRI that uses the findings of the MRI, a biopsy that uses the findings of the MRI to be able to guide the biopsy. Okay. And so there's been a ton of systems that we put out of there. You probably heard the Artemis, the Euronav, the Coelis system. I mean, every single company now has some type of fusion system. And what they do is they try to identify the lesion in the prostate and they merge that within the ultrasound image so that lesion can be targeted. That's what we call true fusion. There's another things that is cognitive biopsy, cognitive fusion, or cognitive targeted biopsy. And that's something that is becoming a lot more popular now with transperineal prostate biopsies, because doing a cognitive targeted biopsy is a lot easier when you're doing a transperineal approach than doing it through a transrectal approach. And that's because your needle is traveling completely perpendicular to the prostate, actually parallel to the prostate. So it's easier for you to, in your mind, see where the lesion is and see where the needle is going. When you have a transrectal approach, your needle is orthogonal. So your needle is shooting at an angle. And so now you're, instead of looking at a YX axis, you're looking at a YC axis, and trying to do kind of cognitive targeted biopsies transrectally is very, very difficult. And that's why most people use fusions for those. You might be seeing a lot of patients doing targeted transperineal biopsies that are transitioning to the targeted approach, because the data have shown that a targeted approach is is almost comparable to a true fusion biopsy. So a targeted transperineal, very similar to a fusion transrectal.
Now, micro ultrasound, what is that? And is it going to replace an MRI, or does it complement the MRI, or?
So I think that it is both. I think that replacing is a little bit of a pipe dream right now. Let's talk about micro ultrasound. So micro ultrasound is a high frequency ultrasound. So our standard ultrasound probe that we use to just, in a way, identify the prostate, measure the prostate, that's usually between 8 to 12 hertz. The micro ultrasound goes up to 29 hertz, and that allows you to start looking at more resolution within the prostate. So you can see lesions, kind of like you can see on an MRI. And that allows you to be able to identify patients that potentially can have concerning lesions that are deemed necessary for biopsy. Now, the advantages of micro ultrasound is the fact that you don't have to go in a tube for 20 minutes. And for those that are claustrophobic, that's nightmare. And so for those patients, it's very, very advantageous. Two is the fact that you don't have to have the gadolinium test that people don't like getting, and for the right reasons. Or two, for people that have pacemakers, that have metal in their bodies and stuff like that, that they cannot get an MRI for. Now, today, micro ultrasound cannot replace MRI. We don't have enough quality data to show that it does. We have a lot of clinical trials on MRI showing that it's a good test for detecting clinically significant prostate cancer. We have a lot of retrospective data showing that micro ultrasound might be equivalent. There is a clinical trial that Dr. Klotz is leading out of Toronto called the Optimum trial that is looking at micro ultrasound alone, micro ultrasound plus MRI versus MRI fusion biopsy. And that is going to answer some of your questions, Nancy. Is micro ultrasound good enough to replace MRI? So comparing the micro ultrasound only versus the MRI only arms, or is it going to be additive with that middle arm cohort where you're going to do micro ultrasound plus the MRI? I can tell you that in my experience, the sensitivity of the micro ultrasound is higher, but that means that we biopsy a lot more lesions that end up being negative or Gleason 6. So I think that in that regard, it's a very helpful test when it's negative. And that's usually what our how we use it at FoxJ's the most is for those men that have a negative MRI or have Gleason 6 prostate cancer, but they have this pesky PSA that keeps rising that is making the urologist very nervous. And so that's what we use it for, because if the micro ultrasound is negative, then the chances you have something aggressive there is really low. And in some patients, we combine it with other biomarkers to help us either add more confidence to that test. So I think that it's a very useful test. It's limited. I think that anterior zone tumors are still difficult to visualize with the micro ultrasound. The peripheral zone is excellent, but although the company has made updates, we have a better way to visualize the anterior zone, but it's not perfect. And I don't think it's even close to MRI yet. But again, time will tell. With further updates, I think that we'll get better. But I think the technology is here to stay and hopefully becomes more ubiquitous within the US.
Is there any risk of sepsis from?
No, I mean, the problem is that, so yes and no. So if the micro ultrasound is being used only for a diagnostic tool, just like an MRI, the risk of sepsis is low. It's zero. There is no sepsis.
Right.
However, in a lot of practices, they do a biopsy based on what the micro ultrasound results do. So depending on what type of biopsy is being done, well, the risk of sepsis is there. So if they do a transrectal biopsy, your risk of sepsis is 2%. If they do a transperineal prostate biopsy, the risk of sepsis is a lot lower. So it depends. I can tell you that in my personal experience, doing transperineal prostate biopsies with the micro ultrasound is a little bit challenging. Not impossible, but a little bit challenging. But because the device was in theory made for transrectal prostate biopsy. So I think most people that are using the device for biopsies are doing it transrectally. We
Mhm.
do them transperineally, but that's with added effort. And typically we do just the targeted with the transperineal with the micro ultrasound probe, and then we use the standard probe to do the rest of the biopsies we need to do.
Right.
So as we're moving along and doing periodic PSAs, how do we decide when to do imaging? And I think the imaging piece you kind of told us is a PIRADS 5, you're going to get a biopsy. But how do we know with our PSAs, and then moving on to the imaging, and then to the biopsy? How do we know? How do you determine when you're going to move toward imaging?
Exactly. No, that's a good question. So we don't have any I mean, there's protocols available, but they're institutional protocols. And the institutional protocols that are available that people quote all the time are very aggressive protocols. You know what I mean? They're like the Hopkins protocol. You get a prostate biopsy like almost every year, regardless of what you have, just because, again, these protocols were developed when we didn't know active surveillance was safe. And so they were very, very conservative. There is no guideline that tells us what to do. So it becomes a physician and patient discussion about when to do an imaging test, when to do a PSA test, and when to do another prostate biopsy. I can tell you that, to me, it depends on a couple of things. How much Gleason 6 scores you have in your prostate. If you have one less than 5%, then my excitement to do a confirmatory biopsy within a year is low, especially if your PSA is staying pretty much stable. If it's several cores of Gleason 6, we know that your risk of upgrading is a lot higher. So that patient, I might be asking them to get a biopsy, at least a confirmatory biopsy within a year, versus someone that has lower volume cancer, I might skip it to 2 years. I think that once you get that confirmatory biopsy, which is the one that confirms the fact that you don't have more aggressive cancer, and that is typically done within 6 months to 2 years' time, then you become more lenient. I think that you start figuring out what the natural history of the cancer is. If you don't have an increase in volume and you have an MRI that doesn't show a lesion getting worse or no lesion at all, you can push the other biopsy 3-4 years down the road, as long as there's nothing exciting happening with the PSA. But that becomes a very individualized decision. Also becomes the age of the patient. I mean, you're a 50-year-old, you might be a little bit more conservative than someone that is 75 or 80, you know what I mean? Because their risk tolerance is a little bit higher, you know what I mean? The 80-year-old might say, yeah, if I have a Gleason 7 prostate cancer, I might not want to treat it. So why diagnose it? You know what I mean? Just yet. Versus a 50-year-old might have a completely different sense. So I think that there's a lot of things that go into that discussion about when to do it. And it becomes a very kind of negotiation to some degree, an agreement that comes between the physician and the patient.
But it sounds like imaging is moving in a direction where we almost don't need the biopsy. But I mean, so how frequently would we be doing the imaging?
So, I mean, I think that imaging, I mean, I'll probably get it within a year or 6 months, depending on how the lesion looked. Then I'll be careful with saying that we should just use imaging for just following people in active surveillance. And the reason is because I typically, and maybe it might be my practice, but I typically diagnose people with aggressive cancer outside the lesions. And so I think that it's a combination of things. I mean, no one wants to get a biopsy. Everybody's afraid of getting infected. I think that moving towards transperineal technique will at least alleviate some of those concerns. I mean, the invasive nature of the test doesn't change. But I think that the fact that we might have aggressive cancer out there that the MRI might not pick up is not insignificant. And I think that will be a disservice to patients not to be able to do a biopsy at least a couple of years around to make sure that we don't miss that window of treatment. And as I said, is that it's not just because the cancer is going to spread, but it's because of the fact that as the cancer gets more aggressive, you require more treatment. A favorable intermediate risk prostate cancer requires less treatment up front than an unfavorable or than a high risk cancer. And so I think that for patients that matters. I mean, it matters if you're going to get no hormones versus 6 months of hormones versus 2 years of hormones. And that's something that might impact someone's decision. From a radical prostatectomy situation, we don't deal with hormones, but it depends how many people are going to require salvage radiation, and that matters. So I think that as a discussion with the patient, I mean, every patient has what we call the risk tolerance. Some people might say to me, taking the hormones doesn't matter, so I don't want to know just yet, or need the biopsy. For somebody, it might actually really, really matter. So you want to make sure that that person, we do biopsies before that happens. And so I think that everybody's different. And I think you have to make an individualized surveillance plan for each individual person. I think that we cannot put everybody in a box.
Okay, well, on the, the transperineal, you think is safer. Do you think that it is better, that it gets anterior tumors better than the transrectal? And the
It's
other
better.
is do you think that the transperineal biopsies today are safer, easier done than perhaps techniques that were used a number of years ago?
So I mean, there's a couple misconceptions. So people thought, if everybody thinks transperineal, they think about like a grid biopsy, or what we call the saturation biopsy, where people used to get like kind of like what they when they used to get like every 5 millimeter biopsies in patients. And so I think that those biopsies we don't do in the office. Those biopsies are not what we do when we do a transperineal prostate biopsy. I'm not taking any more cores than someone is taking when they do a transrectal biopsy. I'm taking 12 cores plus 2 to 3 cores at each region of interest where the MRI shows. The risk of urinary retention, which was the concern with the saturation biopsies, is the same with just a standard 12 core and region of interest, just as a transrectal approach. We have not seen an increased risk of urinary retention with that approach. Yes, it's a lot easier to sample the anterior zone. You don't have to go through the urethra. You can avoid it altogether. And I think allows you to get that needle higher and get better sampling up there. So I think that the main issue for the adoption, I think, is not the complications. I think it's just physicians not wanting to change or learn a new technique just because they're comfortable with the way they're doing things. And to be honest, and to give them an idea, I mean, the data to date, at least in the infection side of things, doesn't show superiority. So we have clinical trials ongoing. Hopefully the European trial will report soon. We have a clinical trial that has been funded by the Correa that we're part of here in the US that hopefully will report in the next couple of years. But I think that that's what we need to get to move the needle. Some strong level 1 evidence data that shows to people that it really does make a difference. I personally think it does, but I'm a very biased person to ask.
Right. Do you think the technique today doing it is different or superior to the techniques that were used a number of years?
100%.
Okay.
I don't think that, I mean, the technology hasn't changed. I think the technique has been adapted to do this routinely, where in the past was done for very extreme circumstances.
Mm-hmm. And if someone wants to get a transperineal biopsy, how does a patient find somebody?
We just have to ask. I mean, I think that we have plenty of urologists around our area that do them. I think having patients and patient advocates pushing for it, I think has been tremendously helpful, because we've seen an increased uptake on people doing transperineal prostate biopsies within our own collaborative. In Pennsylvania, the uptake over the last 2 years has been immense. Our transperineal prostate biopsies have increased by 50%, which is not seen anywhere else. So I think that, to be honest with you, by having patients ask their physicians if they offer it, or send them somewhere else, that's going to get doctors to start doing them. And yes, I mean, there's plenty of people that do them. I mean, I hope that with the new trainees coming out being more comfortable with transperineal approaches, they're going to be the new workforce that comes out. And I can tell you that the majority of our trainees, that being fellows or residents, are not doing transrectal biopsies when they go into practice. So at least there's a good number of people coming out of Temple and Fox Chase that are not going to be doing transrectal prostate biopsies. So I think that's moving the needle.
Good news.
Yeah, well, I'll tell you, you've been so helpful today. I think you've just about answered all of our questions. But I have another imaging question, I think, and I don't know. what's it, PSMA, is that what it
Oh, yeah,
is?
PSMA.
You know, we don't know a lot about it, but I mean, it sounds like an excellent way to follow someone, or, you know, someone has a recurrence. I mean, what do you think about that?
So PSMA PET is a radioactive ligand that it binds to the PSMA protein in the membrane of prostate cancer cells. So it's very specific to prostate cancer. Now, it's a very, very useful staging test, meaning to figure out if someone has prostate cancer outside the prostate itself. If it's in the lymph nodes, it's in the bone, it's in the liver, in the lungs, something like that. I think that in the low risk, intermediate risk setting, the data on the PSMA positivity being associated with clinically significant prostate cancer is still developing. I'll put it that way. It's not a clear-cut thing. There are some countries in Europe that are using fusion PSMA MRIs. So they're combining MRIs with PSMA PETs and making sure that the lesion that is being seen on the MRI is also PET positive. And that will be helpful to reduce those people that have benign lesions. And I think that that's going to help reduce the amount of unnecessary prostate biopsies. I think that in following patients with active surveillance, I don't think a PSMA PET is going to be terribly helpful in telling us if we're going to biopsy or not, because we know you have prostate cancer. So just having a PSMA positive prostate lesion is not going to tell you more than you probably already know. But I think that in the landscape of treatment, especially for those with very high risk prostate cancer, is changing. I mean, the data shows that surgery has not been shown to be advantageous for men with node positive disease, and radiation has. So in my clinic, if I have a patient that has node positive disease that PSMA PET, they don't get surgery because there's no data to support that. Might data come up in the future? Maybe, but not current. That's not the standard of care right now. And I think that it makes sense. I mean, if you have disease that is metastatic, doing a very localized approach such as surgery doesn't make a lot of sense. You want to get radiation and most likely some systemic therapy in the form of hormones to be able to cure that cancer. So I think that in the staging setting is very, very useful. I think when it gets combined with MRI, is going to help us reduce the amount of patients that are going to avoid a biopsy, those that have PIRADS 4 lesions and those that have maybe a PIRADS 5 lesion that is just because of focal inflammation or something like that, focal prostatitis, that is not PSMA positive. So I think that it has some role, and I'm excited to see where it takes us in the future.
Do you have any more questions, Nancy?
No, I think some other people might have some questions.
Right. Well, thank you very much. I mean, it's just
my pleasure.
so clear in these answers. You know, it's just wonderful to talk with you about this.
Thank you very much.
No, my pleasure.
That was outstanding on all of your parts. My head is exploding. That was such a wonderful primer on imaging, and I knew that this would be good. And two, I just wanted to compliment you, Dr. Correa, on your very intelligent approach with regard to gadolinium. The gadolinium issue is something that ASPI raised years ago when we were first formed, and I think we were kind of scoffed at for even speaking of it. But based on what I heard from you, is it is a real thing, and it is something that people need to be aware of. And so you have a very advanced approach to minimizing that. And I've always been appreciative of the fact when I've dealt with you, and you've been my urologist for a couple of years now, I've always appreciated the fact that you're very aware of trying to reduce my discomfort, my pain, and my anxiety, and that the patient needs. What you offer is what the patient needs, an awareness of the patient's anxiety. Now, because you filled my head so much, I kind of need some clarification. You spoke of the targeted biopsy versus the fusion biopsy. Could you kind of review that for me, because I wasn't able to capture all the notes I wanted to capture?
Sure. So fusion biopsy, when you talk about fusion, you're using a fusion system. So you're using some kind of technology to allow you to fuse the MRI images to the ultrasound. That typically is something that was introduced. So I'm talking about Artemis, Euronav, Coelis. I think BK has its own system, and everybody's a little bit different, but they'll do the same thing, which is bring the information from the MRI to the ultrasound so you can be at least as accurate as you can possibly be in getting that lesion. Now, when people were, these fusion systems were expensive and are expensive, and when MRI started coming into play, people are asking, can I just kind of in a way just look at the MRI, look at the ultrasound, and kind of fuse the images in my mind, do what we call cognitive. So the urologists are kind of doing the fusion themselves. For a transrectal approach, that's very, very challenging because your needle is traveling in 3 different directions. It's traveling in an angle. So for you to guess that you have this lesion here, but your needle is going from here, you have to guess when you have to shoot the needle so it hits it that way. And that's where the fusion system becomes very helpful. When you transperineal, your needle is shooting completely parallel to your prostate. So it's easier for you to visualize the MRI and see where your needle is and where it's going to land. So aiming is a lot easier in that case. So a lot of the data coming out here from doing transperineal technology have shown that doing true transperineal fusion, which is using one of these software and instruments to help you note that get the lesion, or having the urologist do it cognitively, they're very, very comparable. So that means that the urologist doesn't need to invest into a new completely system to transition to transperineal prostate biopsy. And I think that will be helpful because then people will be more happy to adopt this technique. They're less likely to adopt it if they have to pay another $100K to be able to add the transperineal fusion system.
That makes a lot of sense. And thank you. That was very helpful. With regard to minimizing the imaging, whether it's micro ultrasound or MRIs, is there anything beyond the crude tool of the PSA that might be helpful in minimizing that? Urine tests, blood tests, things of that nature that might be helpful in minimizing the number of imaging tests.
Yeah, I think that the imaging is can be a helpful, it can be a curse. You know what I mean? I tell my patients this all the time. There's the people that have a very low volume Gleason 6 that have a Parets 4 lesion that probably get more imaging and more biopsies than the guy that never had the MRI that had the same biology and the same biopsy done or had a negative MRI. And the reason for that is because once you see something on an imaging, you have to follow it. So I think that you just have to be mindful about the information you're getting from the biopsy and the information you're getting from the MRI. And I think that if your lesion is negative on biopsy, then it's negative on biopsy. You don't have to keep trying to beat the same horse multiple times to prove that that's the case. The issue with the other testing is that you are at risk of getting conflicting information, and that can be very disconcerting to patients. So for instance, I had a patient, I think was sent by NCAN to me, that had low volume Gleason 6 and had a Decipher score that was high. And the guy's losing his mind thinking that he needs to remove his prostate. The reality is that those tests are not validated in the active surveillance setting. And I don't know what they actually add to the equation. It just goes against everything that we know. And so for the patient, it creates anxiety. For a lot of the treating urologists, it creates anxiety. And so I think that we have to be careful about how we order these tests and how we interpret them, because it can be contradictory and sometimes information overload. I think that a PSA density, the PSA gets poo-pooed a lot, but it's not as bad as we think it is. And I think the PSA density is actually a very, very good measure. And there's a lot of data to actually support that more than for a lot of the other things that we have available in the market.
Excellent. Thank you. I don't have any more. Joe, do you have any questions?
I wanted to comment only because Mark and I share the same opportunity to have Dr. Correa as our primary urologist, and but I really appreciated the presentation. It was excellent, or the discussion. It was excellent. Is there anything further to be said about the liquid biomarkers like SELECT or EXO?
Yeah, I think that those liquid biomarkers are very helpful in the patients that have this kind of very temperamental PSA, let's put it that way. Is these PSAs that keep going up or are elevated, and they have had MRIs that had 4 prostate biopsies, and the urologist doesn't know what to do because the PSA makes them nervous and making the patient nervous. And I think that those tests are very, very helpful when they're negative. And that's because as the micro ultrasound, the sensitivity of those tests is really, really, really high. So when they're negative, the chances that you have something there aggressive are really, really low. Now, the problem is the other side of the coin. When it's positive, is not really helpful. So I think that those tests are very, really helpful when they're negative. They're not very helpful when they're positive. And I think they have to be taken for that. But I think that eventually, I think that things are, if we're going to try to minimize the amount of prostate biopsies that we're doing on patients, I think that eventually, before you do a prostate biopsy on anybody, you're going to have a combination of maybe an imaging modality and some one of these tests. And the fact that if you have a positive negative, maybe you consider not doing a biopsy. You have two negatives, great. You can go to maybe PSA every 3 years or something like that. And that's because you still worry about the 10% that you didn't pick up with the MRI alone, with the imaging. So I think that moving forward, there's going to be a combination of both being used before we go just reflexively to biopsy, which I think we're making tremendous strides. You know what I mean? Like, it was not long ago that everybody with a PSA greater than 4 was getting a biopsy. Now we do MRIs before we do biopsies. Now we have grading systems, and we have limited amount of patients that get biopsies just based on PARADS categories. And now we're even saying, hey, does everybody that have a PARADS lesion really needs to be biopsied? And eventually we're going to add things. So I think that the fact that we're moving and putting more kind of forks in the road before the decision of prostate biopsy is done is, I think, is excellent. I think it's excellent for our patients.
That's really good, and Mark, I'm sure you agree with me as well. Part of what we're trying to do within this program, and we'll be talking more about it, is to help the recently or the long-term diagnosed active surveillance patient to be able to select the right technologies, but at the same time to avoid the unnecessary, and biopsy is one of the ones that everybody, I think the medical community as well as the patient, would like to avoid unnecessary biopsies.
100% agree. I think that if we can avoid doing prostate biopsies, and again, I think that there's a significant number of patients that don't need them. I think that hopefully we'll get to a place where everybody feels comfortable. And I think that the results of PROTECT are really, because you put that into context. I mean, 15 years is a long time. And the fact that there was no increase in death in between the observation versus the treatment the cohorts gives me a lot of pause in what am I doing in my prostate cancer practice. And I think that a lot more people with Gleason 7 prostate cancer are going to be watched. I hope so.
I have to thank you all. This has been outstanding. And, I think Dr. Correa, that ASPI is not only about trying to reduce the overtreatment, but also to help men not have the anxiety, the unnecessary anxiety. And I think your style is what we need to see more of in terms of helping the patient reduce anxiety. So we really appreciate that. So thank you all, Nancy and Larry. Thank you. Great question.
I'd also like to thank, from the point of view of both the ANCAN group, which is part of the coalition with ASPI, and I'm a participant in both, as well as the Canadian support organizations. So I thought I knew a lot about the topic, and I think I learned a lot more again today. So thank you very much.
You have all done such a wonderful job in informing us, helping us, guiding us, hopefully reducing our anxiety in this journey. As I said, there's so much unnecessary anxiety in this journey. And I think the work that Dr. Correa is doing, and the work Nancy, you and Larry are doing, it all helps us not only to avoid overtreatment, but also to reduce our anxiety, which in its own way can be as damaging as all of the overtreatment. So thank you, thank you, thank you.